Well, there's a number of challenges. One is durability of response. So we're seeing about 40% durable responses. So what about the other 60% of patients? Why isn't it working? We need to better understand why it works or why it doesn't work. We're starting to see signs that there's CD19 loss, the target loss in some patients who progress, but it doesn't appear to be in all patients. And so we're starting to understand the mechanisms that drive resistance to the therapy and progression. In the ZUMA-1 trial, we collected specimens, biospecimens, samples from our patients, and so we're hopeful we are testing those and hope to better understand the therapy, both why it's toxic for some patients, why it works and doesn't work for some patients, and that data will come out in the near future as well. So those are some of the questions that are out there. And then of course, can we move the therapy earlier, right? So we know we can use it in the relapsed and refractory setting, truly the refractory setting, patients who failed, whose lymphoma has progressed despite 2 or more lines of therapy, but can we give it as a second-line therapy? So randomized trials are actually testing that question. We're actively enrolling patients, and I expect that we'll have that answer, whether salvage chemo followed by autologous transplant if it works, versus CAR T. Which of those should be considered the gold standard second-line therapy? And so ongoing trials should answer that question in the coming years.